Hello everyone, myself Dr. Ashish Jain. I am from Cardiac Anesthesia department. Today we will be discussing about ABGs. ABG, the full form of ABG is arterial blood gas analysis. Okay. So why ABG is required actually? ABG is required to document the respiratory failure and assess its severity, to monitor patients on ventilator and assist in weaning, to assess acid-base imbalance in critical illness, to assess response to therapeutic interventions and mechanical ventilation, and to assess preoperative patients. Usually there are many errors, many technical errors in ABGs which can alter the picture of ABG without alteration in the patient condition. These are actually, if excess heparin is present in the ABG syringe, then it can have dilutional effect on the ABG and it causes decrease in the level of bicarbonate and PCO2. So the sodium heparin should be used, ammonium heparin will alter the pH, and the dry lithium heparin is okay. So what ideally should we do? We should use pre-heparinized syringes. If syringe is flushed if we have not pre-heparinized syringe, then we have to flush the syringe with 0.5 ml of 1:1000 heparin and emptied. Do not leave excessive heparin in the syringe. Second is the size of the syringe. If the size of the syringe or needle is more and the volume of sample is less, then there are faulty results. The syringes must have more than 50% blood in it, and we should use 3 ml or less syringes, or if percent lower values if 1 ml sample taken in 10 ml syringe. So the size of syringe is less, most probably it should be within 3 ml, and the volume of sample is at least 50% of the volume of the syringe. Now if an air bubble is present in the syringe at the time of withdrawal of blood, then it can alter the ABG readings also. Actually in the environment, PO2 is 150 mm of Hg and PCO2 is 0 mm of Hg. So contact with air bubble will try to equilibrate the PO2 and PCO2. So the PO2 will increase and PCO2 will decrease due to equilibration. And the seal syringe, so we have to seal the syringe immediately after sampling of the blood. Now next is the body temperature. The ABG analyzer is controlled for the normal body temperature, that is 37 degrees centigrade. So temperature correction in the analyzer should be done if a patient has increase in patient temperature, the PO2 will increase and PCO2 will increase and pH will decrease. And if there is a decrease in the patient temperature, the PO2 will decrease, PCO2 will decrease and pH will increase. Now the effect of temperature is that machine always analyzes blood at 37 degrees centigrade. If patient is hyperthermic, then the temperature of blood is more than 37 degrees centigrade. So the measured PO2 and PCO2 will be less than the actual PO2, PCO2 if temperature correction has not been done in the machine. If the patient is hypothermic, that means the temperature of blood is less than 37 degree centigrade, then the measured PO2 and PCO2 will be more than the actual values. So it is very important that we should enter the patient temperature in the analyzer. Now the FiO2, very common complaint that what FiO2 is patient is on if patient is on ventilator, and what FiO2 we are giving, because FiO2 not entered while the sample is fed in the machine will give rises to decrease in PO2 or increase in PO2 accordingly. So FiO2 percentage written or should be entered in the analyzer. There are machine errors also, improper calibration, air bubbles in the electrode which can alter the readings. If the temperature of the sample, if ice sample, it can be stored in the glass syringe, plastic syringe 15 minutes for 1 hour in glass syringe. Ionized ABG can be significantly changed after 10 minutes. So the transportation of ABG should be in the ice box or it should be in a glass syringe, or if it is in any other syringe, then it should be iced. Now what are the components of an ABG? The components are pH. PaCO2 is a partial pressure of carbon dioxide, partial pressure of oxygen, PaO2, bicarbonate ions and oxygen saturation and base excess. Others are many machines have many other readings which they give on the ABGs are hemoglobin, hematocrit, sodium, potassium, chloride, lactate, glucose, standard bicarbonate. Now the normal values of ABG are the normal value of pH is 7.35 to 7.45. PaCO2 normal value is 35 to 45 mmHg. PO2 normal value is 72 to 104 mm of Hg. Bicarbonate normal value is 22 to 30 millimole per liter, milliequivalent per liter. Saturation is the normal value is 95 to 100%. Anion gap is 12 plus minus 4 milliequivalent per liter, and the bicarbonate is the base deficit is plus 2 to minus 2 milliequivalent per liter. So how we'll see that ABG is authentic or not. Actually it is a reference table for pH versus hydrogen ions. If hydrogen ion is 100, then pH is 7. There is a formula below by which we can determine that ABG is authentic or not on the basis of hydrogen ions. Now there are 4 primary acid-base disorders, metabolic, primarily two type of disorders, metabolic and respiratory, and out of these metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Now what are the abnormal values actually? So if pH is less than 7.35, this is called acidosis. It can be metabolic or respiratory. If pH is more than 7.45, it is called as alkalosis. It is either metabolic or respiratory. If PaCO2 is more than 45 mm of Hg, then it is called respiratory acidosis. It is due to alveolar hypoventilation. PaCO2 less than 35 mm Hg is called respiratory alkalosis. It can be due to alveolar hyperventilation. And if bicarbonate is less than 22 milliequivalent per liter, then it is called metabolic acidosis. Bicarbonate more than 26 milliequivalent per liter, it is called metabolic alkalosis. Now there are simple or mixed picture also there in acid-base imbalances. Simple acid-base disorders has a single primary process of acidosis or alkalosis. In the mixed acid-base disorder, presence of more than one acid-base disorder simultaneously is present in the patient. pH is regulated by the buffer system. The most important buffer system in the body is bicarbonate buffer system. There is respiratory regulation also, which starts within a minute with good response by 2 hours, and it is completed by 12 to 24 hours. Then the renal regulation, which starts after few hours and completed by 5 to 7 days. The buffer systems minimizes the change in the pH resulting from production of acid. So the main buffer system in human is bicarbonate buffer system, which is present in extracellular fluid, and the protein and the phosphate buffers are present in intracellular fluid. The role of respiratory system, we can call respiratory compensation also this. So it causes elimination of volatile acid, that is CO2. CO2 is a volatile acid which causes acidosis in the body. So respiratory centers in the brain respond to the changes in the pH of CSF and blood to affect ventilatory rate. So ventilation directly controls the elimination of the CO2. So if it can cause hypoventilation or hyperventilation in respect to CO2 to control the pH. Now the role of kidney, it results and it retains and regenerate. It reabsorbs and regenerate bicarbonate, thereby regenerating the body buffer with the net effect of eliminating the non-volatile acid load. It causes hydrogen ion secretion by free urinary hydrogen ion. Minimal contribution is there, ammonia, phosphorus. It causes high bicarbonate reabsorption by the proximal tubule, from the proximal tubule about 90% and distal tubule about 10%. So we have discussed about the acid-base disorders, what primarily this is. In the next class we will discuss about the compensation and management of the acid-base disorders. Thank you.